Hello all. So I will be discussing about the evaluation and the investigations of a subfertile male. In between, I might cover up a bit of management also just to complete that case scenario what I've taken there. So the definition, I don't want to go into details, but for the clinician, these two terms doesn't make much of a difference. That's my take. And there is this beautiful technique of MICC where you just get few sperms from the male and be done with that. If this is there, so why do we really want a full male evaluation? So what I would like to argue is we definitely need the male evaluation because the IVF ICSI may not be necessary for all couples. And yes, affordability is definitely an issue in many of our patients. And insurance coverage is again an issue. Of course, in some states in the United States do cover, but here I hear that some of the companies like Mahindra are coming up to sponsor the IVF ICSI, but again, things are not very clear. So as a whole, most of the insurance do not cover the IVF ICSI. And yes, theoretically, there are risks of IVF ICSI like multiple pregnancy and also the severe OHSS. And also, occasionally we might come across these orthodox people wherein there are few religions where they do not accept ICSI and also even the gamete donation. I don't want to go into the details of this table, just that a few religions like Catholics, Orthodox, they do not like IVF, ICSI and the gamete donation. And yeah, also in China, this article is from 2016. So I see here that even the gamete donation is not preferred in China as well. Yeah, so these are the reasons why we should give a chance to the male uh, to see if we can improve or tweak up the male factor. Male factor, as you all know, causes a significant psychological burden, and the man is no more the man now because he's unable to father a child. And during this workup of male infertility, we might also pick up some serious conditions, some of the genetic factors, some of the chronic infective pathologies, and also some endocrinopathies like hypogonadotropic hypogonadism, some of which are also actually treatable. So that's why evaluating the and also managing the male infertility is essential. So coming to the evaluation aspect, so when a male infertile guy and the couple walks into my chamber, being an andrologist, I ask first what is the married life and since how many months or years they have been trying. The third question I would like to ask is about the female age. Most of you, I think the gynecologists are watching this. You all know the importance of the female age. So when you compare the fertility potential of a woman when she was 25 years and then when she is 38 or 40 years, it just drops down significantly to just 5%. So if somebody couple, if the female comes with the age of around 40 years, definitely I would not waste the time and of the male. Instead, I will be happy to refer this couple to my reproductive medicine team so that they can go ahead with whatever the ICSI or whatever the gamete donation and so on. So female age definitely important. And the next thing I always ask the male partner is, do they have any sexual dysfunction? We are sorry that Dr. Paras couldn't complete his presentation. So what I would like to stress here is erectile dysfunction and things like premature ejaculation sometimes could be the cause for the infertility as well. I've been practicing in Bangalore. I see well-educated couples married for 4 to 5 years. Still, they haven't consummated their marriage. Just because the guy had ED, they tried twice, thrice, 4 to 5 times, it didn't happen, and they just stopped at it. Now, because the family is putting the pressure, they are coming up for the infertility evaluation. So if you just treat the erectile dysfunction either by tablets, injections, or a penile implant surgery, whatever it is, sometimes these infertile couples do have a solution by just treating the sexual dysfunction. So asking this history, because many of the patients do not come forward and tell this at the first instance unless you dig the history. So this is quite important. And I, being a urologist, I would also ask about if there was any surgery done which could have affected his testis, epididymis, or vas deferens. Some of them could have had undescended testis. They would have undergone orchiopexy, that is the fixation of the testis from the undescended position to the normal scrotal position. And there are papers saying that those who have this undescended testis at birth, they have this altered germ cell maturation and so on. Even if this undescended testis is being brought down to the scrotum, still there could be some amount of this germ cell maturation issues. And also torsion testis, sometimes if the patient presents after 6 to 8 hours, then he would have undergone orchidectomy. So yeah, and again during inguinal hernia surgery, the vas could be injured when they are mobilizing the spermatic cord and when they are trying to place a mesh in the inguinal canal, sometimes the vas can get injured. This becomes important when somebody has undergone a bilateral inguinal hernia at the young age, especially these indirect hernias present at the age group between 25 to 35. So, and also when they're dissecting a hydrocele, if there was some pus during the hydrocele surgery, and during the dissection or while cutting the hydrocele sac, they might have injured the epididymis or the vas deferens. And also during any blind scrotal biopsies, the important reproductive structures can get injured. So I would like to ask the surgical history as well. And medical history, yes, diabetes can cause some amount of retrograde ejaculation because of which there could be azoospermia or some amount of oligospermia. And also sometimes a bad tuberculosis of the epididymis or the vas, where a classic beaded vas appearance can happen and can cause an obstructive azoospermia too. And these days, the testosterone abuse is quite common in those going for the gym, where the gym instructors, they say that take this supplement so that you get good muscle, so that you look good and so on. And these exogenous testosterone supplementation can cause azoospermia, most of which may be temporary, but yes, some of them may need up to 1 to 2 years for them to recover. So this is just a flow chart showing how the testosterone which has been given can cause azoospermia. So if you see here, the exogenous testosterone, it causes a negative feedback inhibition on the hypothalamus and the pituitary. And this suppresses both the FSH and LH. Because the FSH is suppressed, it also affects the spermatogenesis. In this way, people can develop severe oligospermia or azoospermia. And this was the WHO study where they tried to analyze if testosterone can be used as a contraceptive. So what they noted as a secondary outcome in the study that 84% of them, they took almost 3 to 4 months to return to the baseline and to achieve more than 20 million per ml. And only 46% of them, they recovered their baseline sperm density after stopping testosterone. So testosterone should not be given in couples, in a male who have not yet completed family. So that's about the history. I do not want to go into too much details. I am just trying to be as practical as possible. And next, coming to the physical examination, this is one thing which is very commonly missed and should not be taken for granted, especially in a case of azoospermia. One should feel the vas deferens because there could be, because I will just narrate a next case scenario where the vas deferens was missed and what subsequently happened. And basically in the physical examination, you look for the vas deferens and you look for the epididymis because it will give us a vague picture whether PISA is possible, because if it is turgid, then the PISA could be an easy procedure. And also we look at the testicular size. If somebody comes with a very small testis like 1 centimeter, 2 centimeter testis, we might, if you are planning a surgical sperm retrieval, we might plan for a micro TSA instead of just a TSA. And also varicocele is another gamete to be discussed in detail, which I will not do it today. And also, some of them might, especially if one is doing a full-fledged andrology practice, we come across, not very commonly, but we do come across once in a while, people with Klinefelter syndrome who present with azoospermia. And when we examine them, they have this gynecomastia and central obesity and so on. So this is just to say why the examination is important. This was just a couple, 35 and 32-year-old couple with azoospermia. And we have 3 DNB urology PGs every year. This is a teaching hospital as well. And my resident, he first took the case history and examined, and he had missed examining the VAS. And just for your information, that you can just go through the ultrasound scrotum reports when such patients come to you. VAS is usually not commented in the ultrasound scrotum reports. So VAS has to be picked up only by clinical examination. Ultrasound reports mention testis and epididymis and spermatic cord. They do not specifically mention about the VAS in the spermatic cord. So it is always a clinical examination. And when I examined, of course, it wasn't the VAS on both the sides, it wasn't there. So this is classically called as a congenital bilateral absence of VAS difference, that is CBAVD. And this is something which not be missed because there are consequences. And we got the CFTR gene mutation again in the husband. We found a variant, but that was not of any uncertain significance. And the female was also tested, and she was also negative for this CFTR gene mutation. And a few notes about the CBAVD, that is, there are around 2000 CFTR gene mutations, but practically it's not easy to check all these mutations. The American College of Obstetrics Gynecology, ACOG, recommends at least 30 to 50 mutations to be tested. And the thing is, if the female partner turns out to be a carrier of this CFTR gene mutation, that's the reason we got this test in the female as well. There is a 50% chance that the child can present with the cystic fibrosis or the CBAVD. CBAVD is congenital bilateral absence of VAS difference. If she is negative, then the chance is very less, it's just 0.4%. And so that's how we counsel the patients. And also, the MICC outcomes are better in patients who have only CBAVD when compared to CBAVD and cystic fibrosis. Yeah, so that's about the examination part. Coming to the investigations. Yes, this is still the gold standard. I agree, it is not so specific to assess the male fertility, but right now we do not have any other gold standard. So we just stick to the semen analysis as the first investigation that we do. And sadly, we see that many labs, not the infertility labs, the other labs do not stick to the WHO 5th edition, that is the 2010 format. And if the semen analysis is normal, I usually prefer not to repeat it. If it is abnormal, definitely it needs to be repeated. And again, the abstinence time is again different labs and different centers follow differently. I follow 2 to 5 days of abstinence. I advise this for all the semen analysis. And azoospermia should be considered non-obstructive unless proved otherwise. Because we get many patients with azoospermia saying, "Doctor, I think that this is obstructive, so please relieve the obstruction so that I can father a child." No, unless we have some history like some vasectomy, some inguinal hernia surgery, we have some history of obstructive pathology, only then we think in terms of obstruction. Otherwise, most of azoospermias are considered non-obstructive. And the role of testicular biopsies is no more valid these days, just for the diagnostic. In fact, these diagnostic and therapeutic purpose should be behind any biopsy. And this was one of the landmark papers presented from the Neideberger team from the UIC Chicago, from the same center where I did my andrology fellowship, wherein what they concluded in that 2002 paper was that 96% of the obstructive azoospermia and 89% of the non-obstructive azoospermia could be diagnosed based on FSH and testis size. They're not saying 100%, but yes, 96 and 89%. We get some idea with the FSH and testis levels. What they said was if somebody had an high FSH more than 7.6 and a small testis of less than 4.6 centimeter, that could be suggestive of non-obstructive azoospermia. Again, this is all the US data. We don't get to see this big 4.6 centimeter, that is the longitudinal axis. We don't get such big testes in our Indian men. So we do not have a clear-cut cutoff to say whether it is a normal testis or not. So again, like I said, these things are still in a gray area. To say in the simple words, all azoospermia should be considered non-obstructive unless told otherwise. And again, the next step is doing the hormone profile. First, you did the semen analysis. Next, you want to know what hormone test needs to be asked. This is the sentence from the Campbell textbook of urology, where the male infertility chapter has been written by Craig Niederberger, who was my mentor in UIC Chicago, who is also the editor-in-chief, currently the editor-in-chief of the Fertility Sterility Journal. So what he has written in the textbook is that to do, he used to call Big Six. That is 6 tests, which is total testosterone, SHBG is sex hormone binding globulin, and albumin. With these 3, we get to know the bioavailable testosterone. And then we do an LH and FSH, and we do the estradiol. So all these 6 tests are asked at the first instance. ASRM slightly contradicts. It says FSH and total testosterone to be done. If it is altered, then you can go for doing a free T, LH, and prolactin, so on. So my personal take on this is you do this FSH testosterone, then it comes low, then you again tell the patient to give the blood test and again follow up all that. So for all the practical purpose, it's better that you ask all these tests at one go. I'm not saying that you need to do all the tests in the world at one go. At least doing these, because these will help me decide what medications I can give, whether I need to give clomiphene or whether I need to give anastrozole, letrozole. These tests definitely will help me to decide the management as well. And in the testosterone, again, this itself is a controversy. That is, what is the normal value of the testosterone is a $1 million question. And testosterone blood test should ideally be given between 6 to 11 a.m. That is the early morning sample. That is the time when the testosterone levels are at the peak. And the target, that is the minimum that should be, the minimum testosterone level that should be in a male guy presenting with infertility is bioavailable should be 150 and total testosterone should be at least 300. Again, there is no any hardcore evidence to say this. This is what is practiced by most of the andrologists, if not in India, at least in the United States. And total testosterone has 3 components, as you see in the picture there. One is the SHBG bound T testosterone, next is albumin bound, and then is the free testosterone. So what is important for us is the bioavailable testosterone, which is basically of the albumin bound and the free testosterone. And yes, bioavailable, we want it to be more than 150. For example, you take this, you have all the values. You see here the total testosterone is in the 280. You feel it is less, but if you see the bioavailable, it is more than 150. So I would not treat with this patient with any clomiphene anastrozole. There's no indication for any medical therapy in this patient. So again, like I'm stressing it again, this is not a hardcore evidence to say anybody with less than 50, if you treat them with medical therapy, they may improve. But this is all the empirical therapy that we have in male infertility. Optional endocrine test that you can do is the prolactin and inhibin. I personally do not do inhibin in any of my patients because that will not change my management plan. So I don't do it. And like I said, I do what I have been taught during my andrology fellowship. So I may be biased towards what my practice currently is because I just follow what I have been learned from the Niederberger. Yeah, and so few points about the prolactin levels. So more than 15 is abnormal, but again, not everybody who has more than 15 needs further investigation because just a prick, that is the prick that they do to take the blood for this prolactin estimation itself can cause elevated prolactin levels. and stress, exercise, all these can elevate prolactin levels. So again, our American Neurological Association also do not recommend any specific levels of prolactin beyond which it is abnormal. What the some of the studies have shown is that when the prolactin levels go beyond 50 or beyond 100, the normal MRI reports come down. Basically, there will be a pathology if the values are more than 50. And again, this study was in females, not in males. So I personally evaluate further if the prolactin levels are more than 50. Up to 50, I do not repeat. I may repeat this prolactin test, but if it is less than 50, I do not intervene further. And again, our AUA guidelines also say that you don't need an endocrinologist to treat this prolactin levels. You can go well order the MRI of the brain if the levels are beyond 50 or 100. Okay, and again, the third thing is we very commonly see that patients coming with, I have pus cells in my semen, I've taken 2 months, 3 months, 6 months of antibiotics, it is still not cured, doctor. And my doctor and my referral doctor has told me that this is the cause for your infertility. Again, this is still a gray area. Many of the labs, whenever I say labs, I do not mean the IVF labs. In fact, whenever any patient who, for example, if he does a video consultation to me, I always tell him that please get a semen analysis in any of the nearby IVF labs and not in any random lab. Yes, when it comes to this WBCs in the semen, these are basically the round cells. The round cells can be WBCs or the immature germ cells here, immature sperms. So these are confused. Any round cell that they see in the semen, they say it as pus cells or the WBCs, which is not true. Again, there are stains that can be used, Leishman stain and the Papanicolaou stain, to differentiate whether it is round cells or whether it is an immature germ cell or it is really a WBC. So again, what is the consensus that is there? You see this review article. This is AUA is American, C is the Canadian, EAU is the Europeans. So what they say about this WBCs in the semen, the Americans say that it may indicate some infection, whereas the Canadians say no significance, and the Europeans say, yes, it could indicate some inflammation, but it may not be an infection. And again, so what do they recommend? Again, Americans, both the AUA Urological Association and the Society of Reproductive Medicine, they have no recommendation for that. And the Canadians say therapy is not indicated, but maybe in the background of infertility. What the Europeans say is that it may improve the sperm quality, but that doesn't mean that the couple might have a child. So as you see here, all the three these things, they have no specific conclusion on this. So it remains still a gray area. So again, I do not want to leave everybody in the gray area. So what I do in my clinical practice is that I start them on doxycycline. I put them for 10 days. And then I also start them on paracetamol as an anti-inflammatory. And yes, and if I do a repeat semen analysis after 2 weeks or 3 weeks later, if it really shows still the presence of WBCs, and then I do a trust scan just to rule out if there's any asymptomatic pelvic mass or any prostatitis or any prostatic abscess or any pelvic inflammatory mass. Just to be on a safer side, I do it. And if trust scan is normal, I do not intervene any further. And again, I also know that antioxidants have some role in such patients presenting with WBCs in the semen. And again, the evidence of prescribing antioxidants in such scenario is, the evidence is low. Okay, so this, you do a post-orgasmic urine analysis when you're dealing with a patient with an ejaculation or a retrograde ejaculation. Again, this also still remains a gray area because so once the patient has had orgasm, if you check the urine, if the patient had azoospermia and in the urine you see some sperms, definitely we can conclude it as retrograde ejaculation. But in cases where there is already sperms in the semen, and yet then you do a post-orgasmic urine analysis, the sperms are seen in the urine, you cannot really conclude, there is no consensus on this to conclude whether this patient really has a retrograde ejaculation or not. So the next investigation would be a DNA fragmentation index, DFI. The abnormal values, anything more than 25 in SCD and more than 36 in the tunnel assay. Again, different assays are used in different laboratories. Anything more than these levels that are mentioned here could be abnormal. Again, the indication of doing a DFI, I see many of them do it very routinely these days. I personally do not do it as a routine. I do it when somebody is coming with recurrent pregnancy loss, because I am not a big fan of DFI, because at the end of the day, my treatment plan doesn't change. Of course, some argued saying that if the DFI is high, then taking the testicular sperms could result in better ICSI outcomes. And also it has been used to decide whether varicocele surgery is required or not. For example, somebody who has a high-grade varicocele, his semen analysis is normal, but they do a DFI if it is abnormal. Then see theoretically what we have been taught all these years is that if semen analysis is normal, if the patient is asymptomatic, you don't do a varicocele surgery. But the recent concepts that are evolving are that if the DFI is abnormal, even though semen analysis being normal, you can still go ahead with the varicocele surgery, and varicocele surgery could improve the DFI. And the trust scan is basically, we ask this in azoospermia when we think obstruction could be the cause. When you see the semen analysis, repeated semen analysis reports, you see that the volume is very less. It's about less than 0.5, 0.2, so on. And on clinical examination, the vas is palpable, so you have ruled out the absence of vas difference. And you see his hormones are normal and his testicular size is normal. So in such cases, you can ask for a trust scan to just rule out if there's any ejaculatory duct obstruction. And if there is obstruction, of course, transurethral resection of ejaculatory ducts yields good outcomes if there's a partial obstruction. And again, incomplete ejaculatory duct obstruction, if that obstruction was due to the cyst, outcomes are good. But again, if it is a post-inflammatory stricture type of an obstruction, even after doing a transurethral resection of the ejaculatory duct, the outcomes may not be good. Now coming to the genetic test, these three are the tests that are done. So you may ask for, see, theoretically what is mentioned in the guidelines is that anybody who has less than 5 million per ml sperms on the semen analysis, you need to get the karyotype and also the Y chromosome microdeletion. But most of us do not do that in our clinical setting. We do ask for these only when we come across few clinical scenarios. Especially when you're suspecting a Klinefelter syndrome, you definitely ask for a karyotype. Klinefelter syndrome patients, usually, whatever the Klinefelter syndromes that I have seen, they all have come with azoospermia. And occasionally you might see a severe, like somebody presenting with 1 million, 2 million sperms also. But most of them, they present with azoospermia. And they have gynecomastia and they have the central obesity. When you examine, the testes are very small, maybe 1 centimeter, 2 centimeters, so on. And they have very low testosterone and very high FSH, maybe more than 20, 25, 30, so on. So in such cases, you do a karyotype and you can identify this genetic defect. And you ask for this CFTR gene mutation only when you have found an absent vas difference during clinical examination. Otherwise, you do not ask for this test. The third genetic test is Y chromosome deletion. Like I said, it is asked in any patient presenting with azoospermia or somebody who has less than 5 million per ml. And there are 3 types, A, B, and C. And what has been told is that somebody who has A and B, you do not offer any surgical sperm retrieval because they will not have any sperms. And if somebody has C, only then there is a chance of finding sperms on micro TSA. Okay, so the last two slides. I, being an andrologist here in Bangalore, I also get some referrals from the medical oncologists, especially in patients who have had testicular cancers. Just to give a brief idea about testicular cancers are common in between the 25 to 35 years of age. The peak is at that age. That is the reproductive age of all men. So what is given in the guidelines is that if somebody has a testicular cancer, these are the fertility tests that needs to be done: LH, FSH, testosterone, and the semen analysis. And before starting, see, when somebody has a testicular cancer, the first thing that is done is orchidectomy. That is basically that testis is removed. So whatever the sperms are there, that is removed on one side. So you have only the other testis will be having all the fertility potential. So once the testis is removed, then the medical oncologists decide whether they want to start radiotherapy or chemotherapy. And sperm cryopreservation should be done before they start chemo or radiotherapy. That is what is the most important thing. And I get occasional referrals from the medical oncologist for the counseling and also for the sperm cryopreservation. And to conclude the slides, the goal of male infertility treatment should be basically ideally to optimize the testosterone production. I have not gone into the management aspects in detail, so I have not covered the management part. So the testosterone production should be optimized and not through the exogenous route, because that exogenous testosterone will cause azoospermia, and there should be an increase in the endogenous production of the testosterone. And we need to maintain good FSH levels so that the spermatogenesis is preserved, and also reduce the estrogenic effect and relieve wherever the obstruction is, and also reduce the reactive oxygen species, like for example, like the varicocele. And the real benefit of medical treatment in male infertility is a patient presenting with hypogonadotropic hypogonadism, that is, who is presenting with very low FSH, low LH, very low testosterone. In such patients, when we give gonadotropins, HCG or HMG injections, they do really well, but it takes at least minimum of 6 months time for us to see sperm in their semen samples. And when it comes to idiopathic infertility, the recommendation is the very poor in the treatment of male infertility. To summarize, yes, if we target some of these, when we give this targeted therapy in some of these subfertile men, the male factor can be corrected in some of them, and yes, the ART outcomes may be improved. And I'm also the andrology section member in the Urological Society of India. We do have made the male infertility guidelines, which we have published last year. If anybody is interested, you can please go through the USI website. It has a free open access. Thank you.